Hello, everyone, and thank you for attending Science Talks with Cochrane, Power of the Media, How to Translate Cochrane Health Evidence to Inform the Public. Your presenters today are David Tubby, Editor-in-Chief of Cochrane, and Joe Anthony, Head of Knowledge Translation. The Science Talks webinar series is brought to you by the Wiley Network in partnership with the World Federation of Science Journalists and the Association of Healthcare Journalists. Just a few housekeeping items before we begin. At the bottom of your audience console are multiple application widgets you can use. If you have any questions during the webcast, you can click on the Q&A widget at the bottom and submit your questions. We will try to answer these during the webcast, but if a fuller answer is needed or we run out of time, it will be answered later via email, and we do capture all questions. This session of this webinar is going to be videotaped and available at a later point. If you are watching on demand, please email any questions to sciencenewsroom@wiley.com. And now we will begin the presentation with David Tobey, Editor-in-Chief of Cochrane.
Good morning, everybody. I'm very pleased to be able to share this presentation with my colleague Joe Anthony. So we're going to go through a slide deck, and as you know, you can send questions in through the Q&A box. So in the presentation, we're going to talk a bit about why evidence is important, introduce you to Cochrane and the Cochrane Library. I'll talk a little bit about how evidence is changing, pass over to Joe, who will talk about our knowledge translation work and how we work with journalists and the media, and then invite you to send in some questions. So why is evidence important? About almost 20 years ago now, I went to a talk. At the time I was a family doctor in South London, and the talk was given by a professor from Norway, Per Fugeli, Professor of Social Medicine, and he was talking about trust in doctors. And he identified 5 building blocks for trust in doctors. And 3 of them always seem to me to be pretty obvious: compassion, competence, personal care. But the 2 I think that are relevant to the talk today are around sharing power and realism. So people hear a lot about shared decision making, and we talk a lot about that in health in many countries now. But that's really only possible if the people who are on either side of the discussion have a realistic understanding of what healthcare interventions can do for them. So systematic reviews are an important part of evidence-informed healthcare. And the reason that they're particularly important is that they aim to capture all the relevant high-quality evidence that addresses a specific question. So all of us will be very familiar with the fact that if we're listening to the radio or television, we hear about studies published every week, and things seem to go up and down. There's a question in the Q&A box about vitamin D. That's certainly something that in my lifetime has been in and out of favour. What systematic reviews do is to try and pull all the evidence together on a relevant question and answer that question. And by pulling all the studies together, we can develop increased power and precision around effect estimates. We can also look at the studies that were done and whether they were done conducted in a proper way that was most likely to minimize bias. And of course, systematic reviews are the basis for most guidelines internationally. So I'm going to talk a bit about Cochrane. Cochrane was started as a consequence of the very well-used paragraph by Archie Cochrane, who was a British physician and epidemiologist, in 1979, when he chastised the medical profession, saying that it was a great criticism of our profession that we had not organised a critical summary by specialty or subspecialty, adapted periodically of all the relevant randomised controlled trials. And so when Cochrane started up in about 1993, it was really trying to answer that call. Some of you, perhaps many of you, will have heard of Cochrane. Probably the most well-known feature of Cochrane is its reviews. So over the last 20 few years, Cochrane has produced 7,500 reviews, many of which have been updated over time. But actually Cochrane is a worldwide movement, a not-for-profit, independent organisation spanning 44,000 people across over 130 countries. And Cochrane's made contributions well beyond its reviews. So it's a big training organisation. It's helped to develop the methods that are the basis of evidence-based medicine. And it's been a sort of advocate for science and evidence in health. So why does Cochrane exist? Cochrane exists so that healthcare decisions get better. And our main vehicle for doing that is to produce Cochrane reviews, which are regarded as the highest standard of evidence to inform decision making. We do that by identifying, assessing and synthesizing all the evidence that meets pre-specified criteria. We have a very consistent, rigorous process. We use explicit methods to reduce bias to produce more reliable findings. And importantly, Cochrane reviews assess the quality of the studies that are included. The hallmarks of quality, because lots of people now produce systematic reviews. In 1993, when Cochrane started, it was pretty much the only producer, with a few exceptions. But now lots of people produce systematic reviews, and you may want to think, how do you judge what are high quality? And some of the features are on this slide. Firstly, the author team should have published a protocol which laid out their research plan. Cochrane reviews are peer-reviewed at that stage to ensure relevance, to make sure we're asking the right question. And focusing on the right question is the next really important stage. And I'll talk a little bit more about that in a few slides' time. We also take steps to reduce conflicts of interest. So it's not sufficient for author teams to declare their conflict of interest. We expect them also, in some situations, to avoid letting certain people become authors of Cochrane reviews. So if you're employed by a drug company or a device manufacturer, for example, you aren't eligible to be a Cochrane author. And all our reviews are produced by teams that have a majority of non-conflicted authors. So as I said before, we have a consistent and transparent process and methods for producing our reviews. We undertake a comprehensive search, and we try to be really responsible in the way we report our results. We don't spin. We always give our results in terms of absolute and relative effective estimates where we can. We always include some discussion of harms, and we use a system called GRADE to assess the certainty of the evidence that we've found. And when people have conducted research looking at the quality of Cochrane reviews across a range of different parameters, as you can see on this slide, Cochrane reviews consistently score much higher than non-Cochrane reviews. There are some very good reviews published outside Cochrane, but if you look at the bulk of them, Cochrane reviews outscore them. And in fact, this study on your slide here is a repeat of a study that was done in 2008 by the same team. And that showed the same findings, although the difference in the intervening time was that both Cochrane reviews and non-Cochrane reviews had improved substantially in their scoring on the various parameters, but still Cochrane has maintained a distance in its superiority. So we have a strategy to 2020, and I just wanted to briefly mention that because it really encapsulates what we're trying to achieve. We're trying to produce the best quality systematic reviews, importantly, that address the priorities of decision makers, people who use evidence. They can be patients, citizens, consumers of healthcare, they can be health professionals, policymakers, people who are writing guidelines, and so on. The second part of our strategy is that we really want our evidence to be accessible and used. If it doesn't inform decision making, then we would argue that it's failed in its mission, however good it is. As an organisation, we want to advocate for evidence, and the fourth part of our strategy is around building an effective and sustainable organisation, and we do that including lots of training and knowledge translation activities. So the first goal about quality, we have explicit standards, which is the document on your left. We have a handbook, which is widely referenced inside and outside Cochrane. And we have our own software, which Cochrane authors have to use if they're going to complete a Cochrane review. So if you're thinking about a research question, particularly about a treatment, a medical intervention, or surgery or something, what do you need to know? Well, the first piece is this thing we call PICO, P-I-C-O. You need to know what the population of interest is. So it might be people with Parkinson's disease or breast cancer, but in many cases that won't be sufficient. You may need to know what stage of the disease is, what other drugs have been tried and beforehand, and so on. So thinking quite carefully about, if you were in a sort of one-to-one consultation, what's the patient in front of you? Who's the patient in front of you? And what's the intervention? What's the dose? How's it given? All those things. And what are you comparing it with? Are you comparing it with placebo or different drugs? Is it a new drug you're comparing with standard treatments, and so on? And finally, and really importantly, are you looking for outcomes that matter to patients? So often we'll see trials and reviews that look at proxy outcomes, bone density and so on. But in most cases it's possible to identify outcomes that really matter to patients, whether they be well-being or symptom control or recurrence and so on. So what do you need to know when you finish the review? You know your PICO, and you may be asking a simple question: is this treatment better than that treatment? So you want to know, well, is there a real difference between them? And if there was a difference, which was better? And if one was better, how much better was it? And fourthly, and perhaps most importantly, how certain are we about that assessment? And so we use the system called GRADE, I mentioned earlier, to give ourselves a sense of certainty. And I think this is very important, certainly as somebody who listens to the media, reads newspapers and so on. It's very rare in health reports to have people ask the question, how certain are we that this is true? People will present their evidence, their data, as if it's sort of written in stone and it's definitely true. And of course, we know, years pass and nothing much happens, that sometimes what they thought they found can't be replicated by others, and so on. So it's really important to make a judgment about how certain we are about what we've found. And the GRADE system is good because it talks about outcomes. It doesn't talk by individual studies. We say, what's the evidence for mortality benefit? What's the evidence for symptom control? What's the evidence for breathlessness or side effects, and so on? It makes you talk about harm. It makes you talk about relative and absolute effects. So, when you see reports that talk about a 20% improvement in mortality or 50% difference in mortality, you may want to ask yourself, well, how many people out of 100 does that mean? And you'll know that if you have the absolute effects. It talks about certainty. I've mentioned that, and it also helps you move away from what scientists have tended to do for many years, which is to have over-reliance on statistical significance. So if you look at old-fashioned trials and systematic reviews, if something is statistically significant, it shows a benefit or a harm. If it's not statistically significant, it's just the same. Well, that, as I'm going to show, that isn't the case, and it's sometimes quite misleading. And you can see that on this slide. Here we have a finding from a review that looks at mortality between one treatment and another. And as you can see, if you look on the column that says relative effect, you can see a risk ratio, which is 1.46, but the confidence intervals span no effect. And so strictly this is a statistically non-significant result. And the team that submitted the review then reported as a no difference, quite misleadingly. But actually, if you look at the results between the one treatment and the other, you can see that there was an almost 4% difference in mortality. And so what that non-statistical significant result is concealing is the fact that the confidence intervals that we have were perfectly consistent with a considerable difference in the treatments. Maybe 4% in mortality, that's 4 out of 100 people in mortality, that's an important difference. And so this is an attempt to show an example where statistical significance can be misleading in terms of its interpretation. Talk a bit about the Cochrane Library. Just a quick picture of the home page. As you can see, we publish on a sort of day-to-day basis. We don't, essentially we publish when our reviews are ready, and we also have editorials, and we collect reviews together into special collections. Across the world, many people have free access to Cochrane, and that can be achieved in a number of different ways, either through a national license, and you can see that in the orange sections on this chart, or because they're living in a low-income country and get access as a consequence of that, free access. And the countries in blue, including the United States, are areas where you have to have an institutional license, usually through a medical school or a health facility or something like that. In 2016, though, 2.2 billion people across 133 countries had one-click free access without having to log in. And we've seen increasing growth of the use of evidence over a decade or more now. 11% increased use of the library to 18 million in the last year, and a particularly high increase in growth in our own site where we present plain language summaries. And that's gone from 5 million to 15 million in the last 3 years. And you might say, well, how you managed to achieve the 300% increase in usage? And we think we know the answer to that, which is that we started about 5 years ago to present our summaries in different languages that were easy to find, easy to identify. And what's happened is that the use of that facility by people in Spanish and French-speaking countries has really increased, and I think it's a large part of that tripling over the last 3 years. So I'm going to talk a bit about how Cochrane can improve decision making, and one of the most important ways that we contribute is by our reviews being included in guidelines. And here you see Marie-Paul Kearney, who until recently was Assistant Director General at WHO, talking about the increased use by WHO within their guidelines of Cochrane reviews. So over the last 3 or 4 years, in every year, 75% of WHO guidelines have included Cochrane reviews. But individual reviews can also have a spectacular impact also. This slide demonstrates a review that was done by an international group of authors, including people from the US Cochrane Center in Johns Hopkins, where they looked at the relative safety of 2 drugs, bevacizumab and ranibizumab, for age-related macular degeneration, a common eye problem. And the issue was this, that the only drug that was licensed for use is ranibizumab, but actually bevacizumab was also found to be similarly effective at an absolute fraction of the price. Same drug company produced both drugs, and so they were very keen to limit usage to the more expensive ones, unsurprisingly. And there was general agreement the drugs were similarly effective, but there had been a suggestion that the cheaper drug was more harmful. And so this international group looked at that question and found fairly convincingly that there was really no difference between the two. And as it happened, we were having our major conference that year in India, and the lead author, who was an Italian called Lorenzo Mocha, bumped into this lady on the photograph on the left, who is the chief pharmacist and information specialist for a large chain of eye hospitals in India. And what she was able to do, reading the review, was to change the way that the drugs were prescribed in her clinics, which must have saved them vast amounts of money, given the massive price difference. And that's been something that's been discussed all over the world, and this review has been quite influential in many countries in changing government policies. Before I hand over, I just want to talk a bit about how evidence is changing. This is a picture of Carl Hennigan, who's director of the Centre for Evidence-Based Medicine in Oxford. Could easily have used a picture of John Ioannidis, who works at Stanford, both of whom are very experienced researchers in systematic reviews and have been part of the sort of introspection the evidence movement has been having about how good is our evidence, how reliable is the evidence that we produce. And in some sense it has become a crisis of realism, so people worry about drug companies, then their influence, whether we're asking the right questions, whether we're involving patients and end users enough, the conflicts of interest of authors and trialists, limiting our studies to randomized trials, lots of evidence of scientific misconduct, studies not really looking at harms as well as they look at benefits, and myriad causes of bias in all the studies that we look at. So this criticism has built over the last 2 decades and has really helped us understand when the evidence is really trustworthy and when we have to be skeptical. But as we have become more introspective, the world has moved on, and so you will know that in the outside world now people need answers much more quickly, growing interest in real-world data. Evidence questions have become more complicated, and we need to be more versatile. And as I think Barack Obama called precision medicine, people want to think about how not the healthcare of populations, but the healthcare of individuals. So, in thinking about that, we've been thinking about how our reviews should change in the next 10 years. And so we have 4 main goals. Firstly, and it may sound obvious, is to make sure we're asking the right question. So when I was in Australia recently, I asked somebody quite senior in their health department, what are the most important questions for you? And he said, really, the most important questions in Australia are the health of indigenous populations, because they traditionally have very poor health and very poor health outcomes, and we really want to target our treatments to try and improve that situation. So it immediately makes us think about how do we make sure that our reviews are relevant to the most disadvantaged and unhealthy populations. Over the last few years, there's been a massive interest in comparative effectiveness research. So not just thinking about does this drug work better than that drug, but thinking about what in this situation, what's the best drug? So how do we compare lots of drugs? And thirdly, how do we make sure that the way we give treatments, even if we know the treatment's effective, how it's administered, who gives it, and in what circumstances may be important. And looking at how health systems are configured is also really important. We need to look at the right data. So there's increasing interest in the sort of relative inadequacy of the reports in scientific journals, and questions about whether we should be looking at the raw data, the individual participant data, or whether we should be looking at different forms of data altogether, non-randomized studies, big data, and so on. Whether using the right methods are changing all the time. On the screen you can see a picture of a network diagram looking at multiple treatments, some of which are being compared against each other, but some that haven't, and thinking about how you can use all the data to give yourself a ranking of which drug works best, so-called network meta-analysis. And finally, we need to think about how our evidence isn't just published and forgot about, but it reaches the people that need it in a form that they can understand it and use it and really action it. So my last slide is that these are really interesting and challenging times for evidence. There is still a great need for high-quality evidence, sufficiently produced, but the types of evidence that people are producing is changing, and we're having to change to address that. But really, a really important piece of that is engaging with decision makers and other evidence users. So now I'm going to pass over to Jo, who also has some slides.
Hello, everybody. Good morning to you all. I hope you can all hear me. Yes, so carrying on from that, because I think it's quite a neat segue into we do all this, but this only really matters if we can maximize the impact, the dissemination, the uptake, and the use of Cochrane evidence. So that's where our knowledge translation strategy plays a key role. Knowledge translation for us is a relatively new operation and implementation. It's part of our vision for the future. If you think that Cochrane's vision is a world of improved healthcare, where decisions about health and healthcare are informed by our high-quality, relevant, and up-to-date research evidence, then KT, as we call it, knowledge translation, exists to ensure that Cochrane evidence is informed by the needs of our users and informs the health decisions of our users. So essentially, this is all about making sure that our health evidence is accessible to the people that need it the most, to decision makers globally, and in the right formats that they need it. And as a broadcast journalist for 20 years, coming to Cochrane, I suppose after working in media, and particularly health reporting, I know just how important the role that you guys play as media, as intermediary audiences in getting the message out to our key audiences, be that the general public, guideline developers, policymakers, or research funders and research managers. So KT really does encapsulate everything that is comms, dissemination, it's media, it's marketing, it's events, it's language translation, to ensure that we get the right information out to the right people. It's about ensuring that our reviews respond and are relevant to the needs of our stakeholders, and most importantly, are presented in a way that really facilitates the use of that evidence. It's no good if they are not easy to understand, they are too complex, they're highly vaulted in a database. They've got to be accessible, they've got to be timely and topical, and they've got to relate to mass audiences. So that's what Cochrane's knowledge translation is all about, promoting the uptake and use of our health evidence. We see there's four main audiences, as I've identified: consumers and the public, health practitioners, policymakers, and healthcare managers, researchers, and research funders. And there are intermediary audiences like yourselves as the media, like guideline developers, that we really access and we want to work with on a day-to-day, week-to-week basis in order to ensure we get the evidence into the right hands, the people that need it the most. So we do a lot of work with the media globally. I suppose that's more traditionally through the channels of traditional media, be that print, broadcast, publication, but we're also in the multimedia land. Social media is massive for us. We do a lot of media training with key journalists and news editors globally. We target the messaging, so we make sure that we share with specific audiences and groups key messaging. We inform policymakers. We use our strategic partnerships to be able to platform advocacy issues or further developments. And most recently, particularly with KT, we are putting a lot of energy and investment into internal education and training, both internally within Cochrane in our global network of volunteers to really understand what knowledge translation means to them, but also in the users of our evidence as well. So it's really important that we speak with those key audiences, be they practitioners or policymakers or consumers, users of our evidence, to say what format is most useful to you, how do you want our evidence, what does a policy brief really matter, and how does it work for you, how can we improve that, so we can upskill, all about ensuring that our evidence is made accessible to the people that need to make decisions on a day-to-day basis. We also operate across the globe and in multi-lingual approaches. We know that only 6% of the world speaks English, So we work in 14 languages and the languages of Cochrane and the WHO. We have had, we do have a huge amount of media coverage on a year-to-year basis, and we have seen that increasing. We know that Cochrane evidence does generate interest proactively with some of big reviews, particularly in global public health topics. We do work very closely with global journalists from key outlets to provide them with a greater context to their articles. We also operate in key markets, key countries, particularly relevant to a topic area, whether that's global health topics or whether it's evidence that we know are really important in low middle income countries as well. So dissemination so far in 2018, this gives you an idea of what we've been doing. Over 20 reviews have been disseminated to key international science and health media. And we do that through quite a rigorous dissemination process where we look at all the reviews that are likely to publish in the next few weeks and months, and we prioritize them through a process that, you know, who are the key audiences that need to know this? What are the key messages? Does this review have the potential to change practice, policy, behavior? And then we target the audiences with a variety of channels, whether that's a press release, whether that's social media, whether it's a podcast, a blog shot, maybe it's a more formal editorial, or it might be an opinion piece in a publication. We decide which is the best channel for reaching the best audience, and we package our reviews accordingly. So, for example, in January, we pushed out a big review about patient reminders to improve immunization rates. We also, earlier on in the year, through our public health group, pushed out a press release about nutritional labeling and calorie intake, which attracted significant global media interest. And most recently, we published only on the 9th of May, two weeks ago, our review on the HPV vaccine, which had been a review, long-awaited review of, excuse me, on the effects and the safety of the vaccine, and we are continuing to disseminate that out to the relevant audiences. Here's just, due to time allowing, I'm probably not going to click through these, but these give you some of the examples of 2018's coverage, and I'm very happy to share these with you after. I'll certainly send these to you if anybody's interested in having a look at these. But you can see that we span a range of media outlets and a range of channels. So what do? Well, we work with the big reviews. We work with the small reviews in terms of targeting them. But in terms of press, how we would work and the media, how we would work, it's very much a collaborative approach. So our relationship with the media has certainly got closer in the last 3 to 4 years. We normally would not only reach out to them quite early on in the editorial process, but we would also reach out to the author team, and we would reach out to the funder, and we would let them know that this review is on its way. Here are the key messaging. We try and keep everything very clear. We determine those key headlines quite early on in the editorial process. We then make sure that the review is relevant and does this cover topics that we know are going to be of policy or public interest. We write and share press releases quite early on in the process. We run press briefings. We do it with the Science Media Centre based in the UK. We also have a Science Media Centre in Australia, but we also know it's similar to Skyline, which you may be familiar with in Washington, that advocates for the use of health evidence and health reporting in the media. So we run global press conferences. We use our wire service, particularly strong relationships with Press Association, Reuters International, CNN, and the Associated Press. And we all know what a springboard they can be globally to countries where you don't maybe have people on the ground that you can disseminate. And we have strong working relationships with the health and correspondence in international media and publications. And I think that's truer than ever before. So not only are we dealing with general news desks and general news correspondents, but we also know the key players in terms of health editors and science correspondents. And we work with them on a weekly basis, keeping them abreast of the reviews that are about to publish. Here's an example of a review a couple of years ago in the New York Times. That's just put there as an example of an opinion piece that we put together with the authors and the review group. And I also wanted to just have an opportunity to just talk about how we can actually work with you more directly. And that is the fact that we operate a responsive press office 24/7. There's always somebody that will get back to any inquiry pretty quickly. Like I say, we connect with you with review authors and subject specialists, and fairly on a day-to-day basis, but also any early in the editorial process. Based on our plain language summaries and our abstracts, I believe that we provide clear, simple messaging in our PRs, in our press releases. We present the evidence well in a balanced way. We collaborate with opinion leaders in science. So, for example, if we are doing a global press briefing, we would, under embargo, during the time that it's under embargo, that we would send that out to the science through our links with the Science Media Centre, and they would be able to canvass the views of scientific experts in that particular topic area, and we would be able to, which goes beyond what Cochrane can say in our independence. So they would be supporting our evidence, commenting, responding to the evidence, and that leads to more debate and takes the review into those key audiences that we can't necessarily do ourselves in that first initial hit. We share information early with you. Our evidence is relevant to the health stories that you want to tell. I was always taught, I worked for The Guardian for a number of years, and I was always told, and I don't think it's changed that much, that the 5 S's really play a part in terms of storytelling and health with their audiences, and that is sex, smoking, statins, stress, anxiety, and sugar. And I think a lot of the reviews that we would target for global press release do fit under those big, wide-ranging global health topics that are interesting and of interest to mass audiences. And we do keep close contact. We work closely with our journalists, whether it's through the independent press officers based in the various Cochrane centres across the world, or whether it's through this central KT department. You can email us, you can follow us, and you can be part of our press list. Just as we come to a close, I wanted to just put together a slide of resources before taking any questions. I think if you're not familiar with Cochrane, I think you should certainly look at what are our systematic reviews video, it's a YouTube video that you can access on the Cochrane Library. We have 3 main websites. We clearly have the Cochrane Library, which is the database where we publish our reviews. We have our Cochrane.org, which is our external-facing website. And then we have a community site, which you can link through to, which gives you a lot more organizational information. And you can link through to that through our About Us section on .org. So it's worth having a look at those, and they'll give you more information about what we do, why we do it, what's important to Cochrane, our key values, more about our strategy. You'll see the reviews on our library and also related resources that link to the reviews. And certainly you can follow us at Cochrane Collab. Our press office email address is there, and so is my personal email as well. So David and I are happy to take your questions. Thank you very much for this opportunity to be able to present to you today. We look forward to working with you now and continue to in the future.
Thank you, Joe and David, for that presentation. We do have a number of questions coming in. We have representatives that will be reading those questions, but as a reminder, we wanted to make sure that members of the World Federation of Science Journalists and the Association of Healthcare Journalists remember that as part of your membership, you have full access to the Wiley Online Library, including the Cochrane Library. Any questions at any time about your membership benefit access, you could reach us at sciencenewsroom@wiley.com. So we'll start now with the questions.
So it's David here. I've tried to answer a few of the questions on the text, but I sort of the speed they were coming in was outrunning me. So if I just go from, oh my goodness, the top of my list here, how do we monitor the reference literature for changes? For example, NYT example from 2015 uses a review that references several one-sync studies who've shown been retracted, at least correct to what's Cochrane reviews regarding. Well, so when we know about these cases where people have their body of work retracted, we are able to use our internal systems to check whether the studies authored by these researchers are included in any of our reviews. And in the case where we identify that they have been, we will then look at those reviews and see what impact they could have had. They may simply have been referenced as background material, but they may, at the other end of the spectrum, have contributed to the data that were presented and on which we've based our results. So in those circumstances, that may lead to we call them withdrawal, but they're really a retraction. We may, because our reviews are frequently amended or updated, we may amend the review such that we take out the trials that are now in question or have been retracted. So there are a number of things that we can do, and we can also flag trials where the researchers have been involved so that they're not included in future studies, or if they are included, it's very clear that they were retracted and why, and people may do analysis with the studies and with the study out just to see if it made any difference and so on. So there are a number of things that we can do in that situation, and because we have a comprehensive list of the studies that are included in our reviews, and we have the possibility of amending or withdrawing our reviews, there are things that we can do in those circumstances, and we certainly have had to act in a number of cases. It seems to be a problem, particularly amongst anaesthetists, where serious scientific misconduct has been shown. But it's also happened elsewhere, and we've acted in other cases. Gosh, there's lots of questions. I'll jump on, but please do. I don't know if people can shout out. How do you factor in industry influence? So, in any study, in any review, all the studies have a detailed there's a detailed table which often adds several hundred pages to the review, but it includes all the details about the population, intervention, comparison, and outcome, and the risks of bias, and it will usually include something around who sponsored the study. And in thinking about how to interpret the evidence, the researchers will always consider whether the studies were industry-sponsored or not, since, as we know, industry-sponsored studies are much more likely to report a positive outcome for the treatment under question, usually one manufactured by the company involved. We also look for other causes of bias, and we look for whether the studies have all found very similar findings, or whether whether they've been looking at the same piece of the question, and so on. So we have a number of different ways of trying to work out when an industry study has influenced the outcome. And in a situation where we have a mix of industry and public-funded studies, it is possible to do analysis to see whether they found different findings. So it's clearly a major issue for us and for the research community in general, this sort of pervasive influence of manufacturers on the evidence that's out there, really. And frequently, obviously, as you will know, when you hear a news report, that's a piece of the equation that's not reported. And in many cases, the companies will have funded the studies, and that just doesn't get mentioned. Well, at least I hope with Cochrane reviews that should be transparent, and the author team, that when they come to consider their conclusions, should be bearing that in mind in terms of the certainty of the effect estimates that they are presenting. Hans Neubert had a question. Individual precision medicine, how can you estimate it? Well, it's clearly an area of development, so I'm not going to present you with an answer, but I think there's a number of aspects to it. Clearly, if you look at large populations in big studies, they will be quite heterogeneous populations, quite different varied populations. But you can look at people at high risk, people at low risk. So that's a start. Increasingly with genomics, you can identify people with or without a gene, and perhaps do a subgroup analysis of people with or without a gene to look at whether the treatment effect in those people was different. So we know that in some cancers, people that express one gene may respond better or worse to the treatments that are available. So that you can do subgroup analysis, you can do regression analyses, you can look at individual participant data, and increasingly I think there will be studies that ask different questions, that look at risk factors and see how people with or without certain risk factors do better or worse with given treatments. So it's a process that we're going through. I don't think we've found the solution as yet, but increasingly I think the methods are being developed whereby we can start to identify people in much smaller subgroups and that share things in common and think about them differently. Treatment estimates, what's the balance between the big diseases and the rich people's diseases? For example, tropical disease in poor countries. I'm trying to think, do I completely understand the question? I mean, there is no question that most of the research in the world is done, certainly the high quality research or the most well-funded research is done in areas of relative affluence. So you do often get in a situation. Oh, you answered it. Okay. What do you do? Often get in a situation where you're trying to make judgments about whether the same treatments or conditions that work in people in affluent countries are going to work in low-income countries where the disease pattern may be very different. Obviously, in many low-income countries, the incidence of non-communicable disease, diabetes, heart disease is increasing rapidly, and so these are becoming as important conditions as the sort of infectious diseases that we're used to thinking about. And so thinking about what treatments work in those populations is really important, and all the relevant research might well have been done in more affluent settings. So so then you have to make a judgment about how likely it is that these treatments will or won't be seen in different populations, and that often comes down to judgment, or it may come down to comparing the research that's done in those settings with the research that's done elsewhere and seeing if you can see a difference in that way. But there's no. So I hope that sort of answers your question. How are we doing? Access to database libraries for journalists and countries with subscriptions. What do roles in national branches play? That differs from country to country. So in most countries, if they see an opportunity to look for a national license, the local centre directors would take a role in trying to advance that, working with our publishers, John Wiley, who obviously also have a sort of worldwide distribution. In general, a national license is a very cost-effective way to allow your whole population to access the content. It means that if you're at home, if you're a carer, if you're a patient, you can have one-click access without cost and without having to register. Whereas if you're reliant on an institution, you may only be able to access it while you're in that institution, or if you're an employee of that institution. So we very much encourage countries to go for a national license. We have a long-term aspiration to increase our open access content. A lot of our content is already freely available worldwide. But for us, one of our major goals is getting to a situation where everyone, everywhere in the world, has free access to our content. That's what we think the volunteers who make up our workforce want, and it's what we are really working hard to deliver with our publishers, I must say. Sorry? Are there reassessments after a while? So we used to have an expectation that every Cochrane review would be updated every 2 years. And although if you look at the updating rate of systematic reviews, Cochrane updates somewhere around 30 or 40%, I think, from memory, whereas non-Cochrane reviews are almost never updated. So we update a lot more than everybody else, but by our own standards of trying to hit 2 years, we fail, because if we have 7,500 reviews, we'd have to publish over 3,500 updates every year, and we don't get close to doing that. We just don't have the capacity or the resources. So in the last few years, we've made a conscious decision to move to sort of needs-based. So teams, the 52 teams worldwide that look after the reviews, will make judgments about what updates are most likely to have an impact on the outcome, on the results, and they'll be prioritizing those reviews to put through for updating. But every year we publish around 550, 600 updates of reviews, along with sort of 450, 500 new reviews. What's that? Yes. I think we have to be careful about that. We try and make sure that we do reviews that are of value to most people. And so if something is a totally established treatment, particularly if it's something that's been around for decades and the research when it first came out may not be very high quality, we wouldn't necessarily think that was the highest priority. But there are times when you want to question orthodoxy and you're suspicious of orthodoxy, and that is the right thing to do. So we certainly, all the treatments that we assess will have been licensed somewhere, and so they will be in use somewhere. So they will already be available to patients or available to doctors to prescribe. And in some cases, as I think your question implies, treatments that are out of date in the United States or Britain will still be being used in low-income settings like sub-Saharan Africa. So because we want to be a universal source of evidence, not just in rich countries, we will review those treatments and usually assess them against other available treatments, or if it's feasible to do this, placebo, and try to provide some form of answer. yeah, I think you have to make a judgment. There are some questions you wouldn't try to answer because you're confident the question's been answered already, but perhaps by somebody else. But where there's doubt, where there's uncertainty, where it's important for end users, patients, health professionals, policy people, then I would hope that we would ask the question whether it was relevant in one country or another. How do you determine the plain language actually are understandable by those with average reading skills? Yeah. Well, I would. In my previous job, I worked at the BMJ, and we used to have a product called Best Treatments, which was available in the United States, produced by Consumers Union. And we used to aim Best Treatments at people with the reading age of 12. But actually, most 12-year-olds can read pretty well. And so even then, it was quite difficult sometimes for people to understand the concepts. In Cochrane, we haven't aimed for a particular reading age, and I'm still slightly uncertain about whether we should or shouldn't, if I'm honest. We have, over the last few years, identified standards and revised those standards to try and make sure that the plain language summaries are done consistently well and are accessible to people. But I'm afraid I would be the first to admit that there are some that are somewhat challenging. Actually, to do a good plain language summary, I think is a ton of work, and sometimes the research teams that are producing the reviews aren't the best people to do that, and yet we may not have anybody else. So we have standards, we have expectations. We've done quite a lot of work on how to do them better, and I think they have improved over the last few years in general. But I would be the first to say it's an area where we could do better, and I wish we could find the way and the resources to do so. I think I might have answered those questions. I'm sure if they were all a bit quick.
I think that's all for our questions. If anybody else has any final questions, please type those in at this moment. We're just about ending our session. Again, if you have further questions, you have the contact information for Wiley as well as for Cochrane. And I'd like to thank our presenters at this time. Thank you, David and Joe, and everybody that has helped out on this Science Talks series of seminars. Please be on the lookout for additional information coming on the next series. Thank you, everyone.